Hi, welcome to my today's class. Today I will be discussing about fulminant hepatic failure. Now, what do you mean by fulminant hepatic failure? Fulminant hepatic failure means massive liver cell necrosis within 15 days of onset of jaundice. We call it fulminant hepatic failure. If liver failure, liver cell necrosis occurs between 2 weeks to 8 weeks of onset of jaundice, then it is known as subfulminant hepatic failure. So this fulminant hepatic failure is an emergency condition. It should be managed immediately. At this stage, it requires decision to make about liver transplantation. Now, there are various causes of fulminant hepatic failure. One of the causes, most important one, is viruses. Hepatitis A virus, B virus, C virus, D virus, E virus, F virus, all these viruses can produce fulminant hepatic failure. Certain drugs and toxins can produce fulminant hepatic failure. Antitubercular drugs can produce fulminant hepatic failure. Halothane, which is used as an anesthetic agent, can produce fulminant hepatic failure. Alcohol, if it produces acute alcoholic hepatitis, then sometimes this acute alcoholic hepatitis may present in form of fulminant hepatic failure. Paracetamol poisoning, acetaminophen poisoning, this can also produce fulminant hepatic failure. So whenever a patient is presenting with fulminant hepatic failure, we will have to manage it immediately. Ischemic hepatitis, which is usually produced in surgical shocks or sometimes as a result of ligation of hepatic artery during abdominal surgery, sometimes in Budd-Chiari syndrome. In these conditions, many times patient may develop fulminant hepatic failure. In metabolic disorders like Wilson's disease, sometimes patient may present with fulminant hepatic failure. Even in pregnancy, in fatty liver of pregnancy, this can precipitate fulminant hepatic failure. Rarely, massive infiltration of liver by metastatic malignant cells can produce fulminant hepatic failure. So these are the various conditions which can produce fulminant hepatic failure. Now I will talk about fulminant hepatic failure in hepatitis B. Now usually these patients of fulminant hepatic failure in hepatitis B, in these patients prognosis is relatively good. They usually recover. Now why this fulminant hepatic failure develops in hepatitis B? Usually these patients are immunocompromised. That is, either they are having diabetes together with hepatitis B, or they are on some chemotherapy that is anti-cancer therapy. Either they are taking methotrexate, they get immunocompromised, and any drug which is producing immunocompromisation will produce fulminant hepatic failure in hepatitis B. That means if patient is suffering from hepatitis B and if he is taking chemotherapeutic agent for the treatment of cancer, or if he is diabetic, or if he is HIV positive, any such condition can precipitate fulminant hepatic failure. Many a times there is reactivation of hepatitis B virus in cases of anti-cancer therapy. Patients who are consuming methotrexate, there is reactivation of this virus which may produce fulminant hepatic failure. Sometimes there is genetic mutation in hepatitis B virus which is present in body, and this virus after mutation can produce fulminant hepatic failure. But the overall prognosis in cases of fulminant hepatic failure in hepatitis B is relatively good. Some viruses like herpes simplex virus, Epstein-Barr virus, viruses like these, Epstein-Barr virus, herpes simplex virus, Epstein-Barr viruses, If these viruses coexist with hepatitis B virus, then they can produce fulminant hepatic failure. Even this herpes simplex virus and Epstein-Barr virus in immunocompromised host, in immunocompromised patients, can produce fulminant hepatic failure. I have already talked about drug reaction, that is acetaminophen and antitubercular drugs. These can produce fulminant hepatic failure, though prognosis is relatively good in these cases if managed at a proper time. In cases of full-term pregnancy with fatty liver, if they develop fulminant hepatic failure, then in that case the chances of fetal death are more. In ischemic hepatitis, again, if fulminant hepatic failure develops, then in those cases prognosis is relatively poor. It is not so good. Now, these patients of fulminant hepatic failure, how they present? The earliest sign of this fulminant hepatic failure is jaundice, and sometimes before onset of jaundice, patient develops personality changes, patient develops antisocial behavior, patient may develop decreased sleep, patient may complain of heaviness in head, sometimes headache, and sometimes many non-specific type of symptoms. Later on, patient will become manic, patient will become delirious, patient may have difficulty in breathing. These all things are because of stimulation of reticular activating system in brain stem. Many a times these patients become violent. These patients will have fetor hepaticus, that is foul odor in breath. Later on, in later stages, patient may go in coma. Patient may develop convulsions, vocal convulsions, which later on become generalized. Later on, patient may develop decerebrate type of rigidity. In decerebrate type of rigidity, there is extension with flexion of the plantar flexion is there, and extension is there, extension of neck is there, extension of whole body is there. So these patients may develop decerebrate type of rigidity. When these patients develop decerebrate type of rigidity, it is said that prognosis is not good. The patients of fulminant hepatic failure many times develop cardiac features. They affect heart. The patient may go in cardiac failure. If patient go in cardiac failure in cases of fulminant hepatic failure, then it is said that prognosis is not good. Patient may develop different type of arrhythmias in fulminant hepatic failure. Now, in cases of fulminant hepatic failure, there are many changes in lungs also. Patient will develop type 2 respiratory failure. Patient may develop cyanosis. This is because of opening up of AV shunts in lungs, and there is mixing of blood of right and left side both. That is, deoxygenated blood gets mixed with the oxygenated blood. Then how to differentiate? Suppose a patient comes to you with fulminant hepatic failure, acute type. And if there is fulminant hepatic failure in some patients of chronic hepatitis, then how to differentiate between the two? This can be differentiated on basis of history. If there is long-standing history of jaundice, and hepatocellular failure, and if suddenly there is deterioration and all features of fulminant hepatic failure precipitate, then you will say that it is acute on chronic hepatic failure. Usually these type of patients are alcoholics. Alcoholics are already in compromised state. Their liver functions are already compromised. So in these patients of chronic alcoholic liver disease, if they develop hepatitis B, then they will develop acute on chronic fulminant hepatic failure. Now in these patients of fulminant hepatic failure, how to investigate them? You will first, if you think that these patients have fulminant hepatic failure because of virus, then in those cases you will go for viral marker study. In viral marker study, you will have to do hepatitis B surface antigen for B virus, hepatitis B envelope antigen for B virus, hepatitis antibodies against hepatitis B envelope antigen, antibodies against hepatitis surface antigen. So these surface markers you should do if you think that it is fulminant hepatic failure because of hepatitis B. Similarly, if you think that it is because of hepatitis C, then in those cases you will have to do viral markers for hepatitis C. Though fulminant hepatic failure in hepatitis C is rare because this virus produces disease of mild variety. So fulminant hepatic failure is rare. Only in immunocompromised host, if they develop hepatitis C, they can present with fulminant hepatic failure. The patients of hepatitis A and E, they may present with fulminant hepatic failure. So in these patients, always do the viral marker study, always estimate antibodies against A virus and E virus. If patient is say of a pediatric age group and if he develops fulminant hepatic failure because of A virus, then in these cases prognosis is relatively good. Patients usually recover with symptomatic treatment. But if elderlies, they develop hepatitis A fulminant hepatic failure because of hepatitis A virus, then in those cases prognosis is relatively poor. You may have to go for liver transplantation. E virus, similarly, if it infects elderlies, then prognosis is good in fulminant hepatic failure. But if E virus infect pediatric age group patients, then in those cases prognosis is relatively poor. So in those cases, in pediatric age group, you will have to go for liver transplantation. So like this, one by one, you will have to do various serological viral markers. Apart from this, you will have to do biological tests, biochemical tests, liver function tests, in which liver function tests you will have to do serum bilirubin. If serum bilirubin level is very high in fulminant hepatic failure, then it may require liver transplantation. It is a sign of poor prognosis. Similarly, if serum albumin level goes down in fulminant hepatic failure, though in fulminant hepatic failure rarely serum albumin level goes down because half-life of albumin, serum albumin is about 25 days. So usually it goes down in chronic liver diseases. But if it is seen in fulminant hepatic failure, then it is said that prognosis is not so good. So you will have to decide about liver transplantation if serum albumin is going down. Similarly, if SGPT levels are very high, if the levels are above 5 or 6,000, then in those cases again prognosis is relatively poor. Serum alpha fetoprotein, sometimes this is erased in cases of fulminant hepatic failure. If it is found to be raised in fulminant hepatic failure, then this is again suggestive of severe fulminant hepatic failure and prognosis is guarded. One of the investigation which is must in cases of fulminant hepatic failure is EEG. With the help of EEG studies, you can decide about the electrical conductivity of brain in cases of fulminant hepatic failure. You can decide whether because of fulminant hepatic failure brain is damaged, how much it is damaged, and whether it can be reverted back to normal or not. The EEG changes are usually classified into different stages. One is the stage A, stage B, stage C, stage D, stage E, and stage F. It is said that from A to D it is reversible, and after D stage it is not reversible. There is some degree of brain death, brain is damaged. When CT scan is done in the fulminant hepatic failure, in CT scan you can see cerebral edema. So if cerebral edema is very severe, then in those cases again in fulminant hepatic failure prognosis is not good. Now whenever a patient comes to you with fulminant hepatic failure, and when these all investigations are done, when you have studied all these things, then you will have to decide how to treat that patient. Before starting the treatment, you will have to explain prognosis of the disease to the family members of the patient. So if you see that in fulminant hepatic failure that amino acid levels are very high. Amino acid is one of the marker of prognosis. If serum amino acid levels are high, that is suggestive of severe massive hepatic cellular necrosis, and in these cases prognosis is poor. If patient is repeatedly going in hypoglycemia in fulminant hepatic failure, again it is a poor prognostic sign. So you will have to assess amino acid levels and blood sugar levels regularly during the treatment, round the clock, that is every 6 hours or 8 hourly. You will have to assess the level of amino acids and the level of sugar, blood sugar. Similarly, acid, base and electrolyte level, it should be seen in case of fulminant hepatic failure regularly during treatment. If there is electrolyte imbalance, that is if there is hyponatremia and hyperkalemia, in those cases again prognosis is relatively poor. During treatment also watch for renal failure, because in these cases sometimes there is functional renal failure which we say that it is hepatorenal syndrome. So if hepatorenal syndrome develops, again it is a poor prognostic feature. Once patient goes in hepatorenal syndrome, it will be difficult to bring the patient back, and this is again one of the feature which suggests, so if suppose patient is going towards hepatorenal syndrome, this is again suggestive for liver transplantation. Similarly, watch for respiratory and cardiac failure in cases of fulminant hepatic failure, because many a times patient goes in cardiac failure because of increased circulation. This is because of damage to the centers which are present in medulla oblongata, which are managing the cardiovascular system. So in these patients, because of high cardiac output, hyper circulatory state, because of fulminant hepatic failure, patient may go in ventricular failure. Similarly, patient may go in respiratory failure. So you will have to watch for features of respiratory failure. Patient may develop cyanosis. In case of these patients, oxygen saturation may go down, level of carbon dioxide in blood will increase. So partial pressure of oxygen and carbon dioxide both should be measured regularly during treatment. If patient develops type 2 respiratory failure in cases of fulminant hepatic failure, again it is said that prognosis is not good. Sometimes patients develop hypotension. This hypotension may occur because of blood loss from the GI tract. These patients, if they develop hypotension, again it is said that prognosis is not so good. In cases of fulminant hepatic failure, many a times patient develops bleeding tendency. This is because of disturbance in coagulation machinery of the hematological system, because whole of the factors which are responsible for coagulation, they are manufactured by liver. So there is imbalance between these coagulation factors and patient develops bleeding tendency. So if patient is developing bleeding, then you will have to manage on these lines. If patient develops infection, you will have to manage infection in fulminant hepatic failure. In fulminant hepatic failure, patient is immunocompromised. In these patients, as they become immunocompromised, as liver is one of the organ which is responsible for maintaining immunity of body, so immune system is compromised, they may develop infection. So you will have to monitor for infections. You will have to do total differential counts regularly on regular basis during treatment. Many a times in cases of hepatitis A, if they develop fulminant hepatic failure, in cases of elderlies, usually hepatitis A virus infect pediatric age group, but if in immunocompromised elderly, if it infects elder person, and if elder person develops fulminant hepatic failure, then in those cases chances of developing acute pancreatitis are very much. So if patient develops acute pancreatitis during fulminant hepatic failure A, then again prognosis is not so good. So management of pancreatitis should be done during the management of fulminant hepatic failure. Overall survival, it is said that it is good in cases of hepatitis A virus, E virus. In B virus, if the prognosis is good, it is not so bad. But if B virus infects immunocompromised patients, then prognosis becomes poor. Similarly, if A virus, if it infects elderly, then prognosis is poor. If E virus infects pediatric age group, then prognosis is poor. Overall survival in fulminant hepatic failure because of hepatitis A is 66%. In hepatitis B, overall survival is 38% if it is patient is immunocompromised. In acetaminophen toxicity, survival is 50% even after perfect treatment. So it is said that if fulminant hepatic failure develops, then overall prognosis is not so good. So one can ask a question that what are the signs of poor prognosis? Then you can say that if liver size is very small, if there is presence of ascites, if amino acids are increased in blood, if there is decerebrate rigidity, if convulsions are present, if patient has developed irreversible damage to brain as evident by EEG, if patient has developed renal failure, if patient has developed pulmonary failure and cardiac failure, then all these conditions the prognosis is poor. The cause of death in fulminant hepatic failure is excessive bleeding. It is because of type 2 respiratory failure, severe cerebral edema, renal failure, severe infections, septicemia, severe hypoglycemia. All these conditions cause death in fulminant hepatic failure. Now, how to treat a patient of fulminant hepatic failure? Treatment of all cases is symptomatic. So, if patient comes to you with fulminant hepatic failure, first maintain vitals. See vitals regularly in ICU every hour. Put Ryle's tube. Through Ryle's tube, you do gastric suction to avoid excessive secretion which may produce aspiration pneumonitis. So aspirate out through the Ryle's tube all the secretions in stomach. Keep patient nil orally. No protein diet should be given, because if you give protein diet, then in those cases more of ammonia will be produced and it will precipitate further hepatic encephalopathy and brain damage. Regularly give glucose by infusion, because these patients they develop hypoglycemia, and monitor blood sugar level. As there is cerebral edema in these cases, manage cerebral edema with the help of mannitol. If it is not manageable with mannitol, then you can use thiopental infusion. Together with this treatment, you will have to give proper calories through infusion so that metabolism is maintained. If patient has developed respiratory failure, then you will have to do intubation. You may have to keep patient on ventilatory support. If patient has developed electrolyte imbalance, hyponatremia, hyperkalemia, you will have to treat that patient accordingly. If patient has developed hepatorenal syndrome, then in those cases you may have to put patient on hemodialysis for renal failure. Apart from this, you will have to do high bowel wash regularly. This high bowel wash will eliminate protein from the high bowel wash eliminate bacteria normal commensals from the intestine, because these normal commensals usually act on protein and produce ammonia. So you will have to keep bowel clear of these normal commensals. So you give regular high bowel wash. You will have to give laxative agents, osmotic laxatives like lactitol or lactulose regularly. You will have to increase bowel motility. As a result of increased bowel motility, all the normal commensals of bacteria which are present in intestine, normal commensals, will wash out, and amount of ammonia produced is decreased, because this ammonia is one of the culprit which is responsible for disturbed mental functions. If patient has developed bleeding, you will have to stop bleeding immediately. You will have to give blood transfusion. Watch for prothrombin time. If patient has prolonged prothrombin time, then in those cases you will have to give fresh frozen plasma. If patient develops thrombocytopenia, you will have to give platelet infusion. So like this, you will treat a patient of fulminant hepatic failure. This is an emergency condition. You will have to decide whether the patient must go for liver transplantation or not. Thank you.